Very good morning to all. I must thank Moita for having a very, very interesting topic in the morning sessions. Presbyopia. Now I know what has hit me. I am a hyperope to start with, though I don't wear near glasses very, very rarely. I'm 50 now, but thanks to yoga I do, but most of the patients are not so lucky to get what they want by doing yoga or eye exercises. It hit me first when my son around 6 years ago asked me, I was doing some coding for him for PlayStation, and he asked me to note down the barcode from the back of the PlayStation. I was trying to hack the code of a game for him, and I realized I'm presbyopic. I couldn't read the barcode. And that point I realized what my patients go through. Earlier it was like so okay for me. So this is the number one problem which hits everybody, all of us, the moment we cross 42. And this is one of the most troublesome problems we will have. Our expectations don't go down, but our vision does. Maybe 20 years ago, maximum things which elderly people required were just sit and read for a few minutes, read newspapers, look after grandchildren. But for ophthalmologists, is presbyopia correction the holy grail? I think I will talk about presbyopic IPCLs. I think I am the right person to talk about because I probably feel I have probably the highest number of Phakic implants to my knowledge, and especially the IPCL. And IPCL is a particular product which is offered is a reversible presbyopic correction, and I have tried my hand at it recently. Now, Phakic IOLs have come a long way. We all have seen different styles and versions of Phakic lenses as we move along. And posterior chamber Phakic lenses have proved themselves to be worthy. There are immense number of users and users going up every day. I, in my personal series, have done nearly 1100 this particular brand of Phakic lenses. I've done PIs, corrected hyperopes, myopes, astigmatisms, and now presbyopes. So, my experience of a Phakic lens coupled with my experience of the iDiff technology, specially manufactured by the Care Group, when I combined both of them, I utilized and I realized, yeah, this technology could maybe work. 3000 iDiff multifocal lenses alone, apart from the other multifocal lenses I do, and I usually am a strong opponent of people who discourage use of multifocal lenses. I was sitting on that side of the fence maybe 7 years ago. I was standing in debates talking against multifocal lenses, but in now my practice, I nearly do 90 to 100 multifocals a month now. And believe me, if I'm doing it, my patients got to be happy. That's why I'm doing it. I don't want to burn my hands making unhappy patients. So let us talk, what is the presbyopic IPCL? So it combines the iDiff technology, which is again a patent by this company, special SMP design modulations on the multifocality zones, and with the patented design of the Phakic lens, both coupled, and I cumulatively have more than 4,000 lenses plus experience. So I thought, let me venture on this. You have variants of 1.5, 2, 2.5, 3, 3.5, and the optic size, effective optic size is 3.5. Another great thing about these lenses is they also correct your refraction. They are not just correcting your presbyopia. So suppose you have a patient with +4, you correct his +4 spectacle dependency and also correct his presbyopia. Suppose you have a pseudo-phakic patient whom you operated earlier, who is -2 residual refraction left by your cataract, correct that and correct the presbyopia also. Can you imagine what it opens for you? It opens a new subset of patients which were long forgotten by you and your practice. All these patients you've operated in the past, they were very happy, but they come back to you and you can offer them a new option. And another great part is, this is a reversible option. Advantages: no high-end surgical equipment required, similar workup like an ICL or a cataract. The only thing you require is a good refraction. A good refraction, especially if you're operating a secondary pseudo-phakic patient who you operated earlier, anterior chamber depth, it doesn't matter that much. You need to have a decent white-to-white measurement. Simpler to start with in pseudo-phakic lenses. There are a lot of papers which have come up. I worked with Dr. Ali on this, presbyopia correction with multifocal lenses. This is a proprietary design and material. A patent is there. And Now this is a video which I'd like to show. This is a patient, this is one of the first patients, you know, where you can actually, this is a patient with amblyopia. So first case, you want to be a little hesitant, you don't want to start altogether. Partially amblyopic patient, hyperopic, +6, 44-year-old man. And what do? You just push in. He had a good anterior chamber depth. I already had told the patient, I said, in case you have a cataract, Prelex is an option. We will not charge you for it. So you see, this is what you do when you start a new thing. You want to be doubly careful. So you do this, put in the multifocal phakic lens in the eye. The patient is happy. Patient was 6'12" and he was N8 near aided. So then second option which opens is all your patients where you operated cataract priorly. You put in multifocal lenses inside. Now you can put in a multifocal piggyback phakic IPCL, which is presbyopic. So you can start operating patients who've been operated by you earlier and now they want multifocality. But the only thing we need to do is get over our fear of multifocal lenses. They are not all that bad. So criteria for exclusion, patients who already have some lenticular opacities, you should look for healthy clear corneas, lifestyle of the patient, he requires more dependency on near glasses, look for occludable angles, macular diseases, and even the best part now is you have a smart toric presbyopic IPCL. Can you imagine the significance? You have a patient with an astigmatism and a refractive error. You can correct his astigmatism, refractive error and presbyopia in one go by a smart lens, which means the lens has got a built-in axis on it. All you need to do is place it at 0-180. It's got a built-in axis astigmatic correction in it. So even the calculations of rotation is taken away from you. It makes it so very easy. Okay, this is our experience. Especially when I was happy with the technology, I had operated one of my OT technicians, who is my favorite OT technician, 8 years ago. And he was pseudo-phakic. So he was wearing glasses. So at times when he would bend the Rex's needle, I said, Ahmed, bhai, kya kiya? What have you done? When I want a manipulator, he handed me something else because, you know, the distance, he's wearing presbyopic glasses. So one day I said, Ahmed, can I put this lens in your eye? You're a pseudo-phakic. I can explant it if you don't like it. After 2 weeks, give it a trial. He said yes. So he was my number 2 guinea pig. I put it in one eye, and after 4 days, he started assisting me in the OT. Even with one eye, he said, sir, it's better. So I put it in the second eye. After that, I contacted the company. I said, now I'm ready to go because the guy whom I trust my OT with, he's happy. So after that, I've started offering it to patients in my clinic. There are some basic principles when you're using it in a phakic patient. I would say evaluate the patient. Patients 47, 50 years old, go for one eye which is non-dominant, go for that eye, correct the age required, maybe 0.25 or 0.5, overcorrect for distance. Suppose the patient is, let's say, -1 for distance. Correct him by 0.75 myopia. Leave that -0.25. What that does for you, it gives you another buffer of 1 or 2 years of extension. Leave the other eye. Do monocular implant. These are the nomograms I'm getting from the company now. I'm planning 2 such lenses in next coming 2 weeks. For hyperopes, overcorrect. Overcorrect the eye by 0.5. That again gives you a buffer zone of 2-3 years extra. So when you operate one eye, this one eye can last the patient anything between 4 to 7 years. The second eye can be planned later on. Now, patient selection criteria is the same what you do for your normal phakic lenses, anterior chamber depth, but suppose it is a pseudo-phakic lens, the anterior chamber depth is not so important. Do a gonioscopy, do a specular count for these patients, measure the intraocular pressure, sizing and vault, and these are the patents which are there for the company. Additional power, it is definitely scoring over the Prelex because Prelex is not reversible. Once you've done it, you've done it. You've taken the natural crystallines out. Believe me, friends, the best advantage with the technology is it's reversible. You don't like it, pull it out. And I can tell you, you won't need many occasions to pull it out. Number 2 is, suppose your patient is not happy with multifocal with Prelex and you've done a multifocal. What do you do now? So advantages, removal of crystalline lens is necessary. Chances of posterior capsular rupture and all the stuff associated with the cataract surgery which is not there. At the best advantage is you have huge number of sizes, all powers available. I have done phakic lenses up to 8.5 optic diameter. This is the size of the lens which I had implanted. And highest power I've done is -32. So the range of the availability also is there. So key for success is a good patient selection. Summary is, it is the way forward. I don't know whether this is the right thing or not, but this is definitely promising.